Breaking headlines tonight out of West Africa. $60 million pulled from the nation's emergency reserve. Not for soldiers, not for missiles, not for border walls, but for buses. And not just buses. Those rusted shells forgotten in scrapyards are now clinics on wheels, rolling into provinces where no doctor has set foot in more than a decade. 740 babies. Delivered not in hospitals, but in the back of refitted buses, a number shocking enough to divide a continent. Is this the boldest healthcare innovation Africa has seen, or a dangerous gamble with human life? Before we go further, take a moment. Drop your city in the comments. Tell us where you're watching from. And more than that, if you had to choose, would you trust an old bus clinic over waiting weeks for a hospital bed? Your experience, your choice. Share it below. Africa Daily. Good news in motion. You're watching a channel built to connect Americans, Africans, and everyone who believes stories can travel further than headlines. If you want to see Africa Unfiltered, subscribe, because tonight's story isn't charity, it's controversy, and it might just change the way you see public health forever. Now, let's begin where the signatures were drawn, in the presidential office, with one decision that split the room in silence. An emergency fund built for war was emptied into health. One signature moved $60 million away from drones and border fences toward buses that hadn't run in years. A choice that flipped the threat matrix on its head and forced every official in the room to decide what security really means. The order was signed under presidential discretion for urgent national needs. Not debated on the floor, not teased to the press, executed, filed, and transmitted to the Treasury before lunch. Budget notes listed the reallocation as a time-bound public health response. The stated goal? Rapid coverage in provinces without functioning clinics. The metric? Maternal survival, malaria intervention, essential diagnostics. Advisors flagged the risks: cash flow, supply chains, political optics. Defense argued the North was volatile. Finance warned reserves were already thin after drought losses. Still, the directive stood. The money moved. Procurement clocks started. What made the room go silent wasn't the price tag. It was the premise. If a nation can spend billions fortifying perimeters, why not spend millions restoring breath? Americans watching this will recognize the split. Most counties in the U.S. will back a new fire station faster than a new mobile health unit. Yet response time, not square footage, saves lives. According to public safety studies and hospital triage research, the window from first symptom to first qualified contact shapes outcomes more than the building's facade. People, if they can reach care sooner, live longer. Simple math, uncomfortable politics. The president framed it that way, not as charity, as strategy. He cited internal maps showing whole corridors with no staffed clinic for a decade, fuel scarcity crippling ambulance dispatch, night births happening by phone light. He didn't promise new hospitals, he promised movement. Most Americans, when asked, assume more beds equals better care. But in rural medicine, coverage and mobility often beat masonry, house call logic at country scale. Inside government, the pushback wasn't theatrical. Generals asked for drones, border chiefs asked for sensors, auditors asked for guarantees. The reply was narrow and brutal. Deaths from neglect had become predictable. Predictable deaths are preventable. Preventable deaths are a policy failure. Funds once meant for bullets would buy blood bags. Fuel, once earmarked for convoys, would power refrigeration for insulin and vaccines. The calculus flipped from terrain denial to disease denial. If this were your county, would you accept a year of waiting for a new wing, or 60 days to deploy coverage on wheels? Not a moral test, an operational one. Most Americans default to the familiar build-then-staff rhythm, but the longer a system waits to exist, the longer people wait to live. That's the part no ribbon-cutting fixes. The paperwork moved faster than the applause ever would. Treasury authorized the draw. Transport received a requisition not for new imports but for decommissioned stock. Health drafted scope for mobile teams. Comms prepared to absorb the blowback without spin. The sharpest surprise wasn't the spending, it was the constraint. The directive would avoid foreign grants in Phase 1 to prove the model could run on national muscle. No donor clock, no conditionalities. Outside the compound, beyond the walls and the language of risk, sat long rows of metal, dusty, dented, written off by time. Their windows filmed over, their tires bricked. The signature inside had set a timer no speech could pause. Somewhere between policy and pavement, those shells were about to change jobs. And when they did, the definition of infrastructure would have to move with them. Generals came for drones and got a health brief. A closed-door session booked for border resilience opened with infant mortality charts. The room didn't explode, it froze. On the record, the agenda read security posture. Off the record, the president argued survival is the first line of defense. Senior commanders cited ambush reports, broken airstrips, fuel deficits. Finance warned the reserve was thin after drought losses. Auditors asked who would own accountability if the bet failed. The response was procedural, not poetic. The order stood under urgent needs authority. Funds were time-boxed. Oversight would run through Health and Treasury with weekly variance memos. The target window was the next 90 days in districts with no reliable clinics or power. Weapons weren't canceled, timelines were. The North would still be funded, the median distance to care would be shortened first. The mood turned when the mapping team projected gaps onto the wall. Corridors with no midwife on payroll. Ambulance routes that existed only in policy. Security officers know terrain. Here, the terrain was time. According to disaster response research and rural emergency studies, the first contact with a qualified provider, minutes, not miles, changes outcomes more than any new building. Americans hear that and still picture the hospital first. Most polls show U.S. voters rank hardware above health in security spending. Yet when a child can't breathe, people call whoever arrives fastest. Human behavior is consistent across borders. If care can move, families will move toward it. No one was asked to clap. One colonel tapped his pen. Another stared at the chart where the red zones didn't blink. The health secretary spoke in numbers. Coverage density. Vaccine cold chain failures. Nighttime birth risk. The interior minister translated those numbers into scenes the room understood. Women delivering by flashlight. Radio calls that never connect. Funerals that feel routine. The pivot point wasn't ideology, it was predictability. Predictable deaths imply preventable deaths. Preventable deaths imply policy failure. If this was your town, would you wait for a new wing to open or accept a rolling clinic tomorrow, even if it looks like yesterday's bus? Most Americans, by habit, trust fresh paint and ribbon cuttings, but delay is a cost you pay in lives, not dollars. People, when given a faster option, choose it. When they see help arriving where it never has, they change how they plan, how soon they ask, how loudly they insist. Inside that room, the human shift was small but visible. The general who opened with drones ended by asking logistics how many routes could be secured per week. The budget officer who flagged optics asked whether local nurses could staff night runs. Opposition didn't vanish, it converted. Not everyone agreed on the route, but the destination, fewer funerals, stopped being abstract. The president closed without slogans. Health would move first, defense would adjust patrols to protect corridors, finance would publish the drawdown path, comms would brief without triumphalism. The surprise wasn't the pushback, it was the constraint. Phase 1 would avoid foreign grants to prove the muscle existed at home. No donor timeline, no conditional strings. If it failed, the failure would be theirs. If it worked, the lesson would be too. Outside, the day kept going. Courtyard heat. Files handed across a desk. Shoes on tile, quick, then quicker. Somewhere in the transport ministry, a requisition packet slid into an outbox stamped immediate, and metal that hadn't mattered in years began to matter again. Waiting for a welder's torch, waiting for a new job title. The procurement order skipped showrooms and went straight to the scrapyards. Mechanics, not sales reps, took the call. A graveyard of buses became the assembly line for a national triage plan. Transport identified decommissioned stock across multiple lots. Inspectors tagged units that could be salvaged. Deliveries arrived in waves, 20 at a time. Frames chalk-marked, VINs photographed, corrosion logged. Conversion yards were set up near the capital and along two logistics corridors to cut haul time. The brief was blunt: strip seats, reinforce floors, rewire for off-grid operations, install medical-grade lighting, refrigeration, diagnostics. Health issued a baseline kit list. Transport handled chassis and electrical. Treasury pushed a weekly spend cap with variance alerts. No imports, no luxury fits, no delay windows, speed over polish. Inside the first yard, the smell changed. Diesel out, disinfectant in. Welders boxed steel rails under the deck for load stability. Electricians ran shielded cable through wall channels. Rooftop panels fed battery banks mounted behind armored covers, rated for a week without grid support. Medical fridges were shock-mounted. Drawers were built for rapid tests and emergency meds. Oxygen and suction lines ran along protected conduits with quick-release service points. Scrap metal turned into sterile light. A nurse walked the aisle with masking tape, marking where to place the exam table, where hands would reach for gloves without crossing the dirty path. Flow mattered as much as torque. Numbers anchored the optimism. Each unit was scoped to cover roughly 3,000 people per month in zones flagged for clinic collapse. Rotation cycles were set by distance, terrain, and expected case mix: prenatal, malaria, wound care, chronic meds. A daily check sheet enforced cold chain integrity. Biometric locks tracked drug withdrawals. Waste was sealed on board for regulated disposal. Uptime targets were set at 7 days continuous with solar and battery alone. The quiet shock wasn't the gadgetry, it was the grid independence. If the road held, care would hold. People adjusted in real time. Old drivers who once ran city routes learned triage basics and radio discipline. Technicians practiced ultrasound on plastic abdomen models. Welders took pride shots of ceiling lamp rigs they'd only seen in hospital dramas. Before, these buses carried commuters who watched the clock. Now, they'd carry patients who watched their breath. The job title changed. The routine did too. According to common behavior studies, when care shows up where it never has, families seek it sooner. And when families move earlier, outcomes move with them. You don't need a journal to know this. Most Americans choose the urgent care that's 15 minutes away over the hospital that's an hour out, every time schedules collide with symptoms. If this landed in your county, would you sign off on a fleet of refurbished clinics over waiting for a new building next year? Or would the optics make you hesitate? The American habit is to trust the ribbon, not the wrench, but speed plus reliability often beats shine plus delay. Human nature bends toward whoever arrives first and arrives prepared. Paint dried. Crosses went on the panels. Old route boards came down. New route codes went up. VIN plates that once signaled retirement now mapped to districts without doctors. Test runs rolled at dusk to stress the lights and the cooling under heat soak. The radios crackled clean. The generators stayed silent. At first light, convoys pointed toward the parts of the map that used to be blank. Dust rose behind them. Somewhere, far from the yards and the signatures, a village would see headlights instead of sirens, and the definition of access would begin to move. Clinics opened with no addresses. Coverage launched before construction. A health system came online the moment engines turned over. Phase 1 set service blocks and rotation cycles. 6 provinces prioritized by clinic failure and travel time. Daily schedules published to district radios. Corridors coordinated with interior and defense for safe passage. Routes were drawn for uptime, not spectacle. Hills and river crossings measured against battery endurance and staff hours. Each unit targeted roughly 3,000 residents per month. Cold chain checks logged at dawn and dusk. Drug withdrawals tracked by biometric locks. Waste sealed on board for regulated disposal. Independence became the feature, not the backup. Rooftop solar and wall-mounted batteries carried a full week off-grid. No diesel generators, no clinic meter to trip the lights. The rollout felt unfamiliar because it skipped the ceremony. No ribbon, no speech, just headlights at first light and a checklist on a clipboard. Teams ran standard operating procedures: triage at the door, prenatal on the left, fever and wounds to Station 2, chronic meds by appointment slot, ultrasound and diagnostics by queue. The goal wasn't to do everything, it was to do the right things fast. Coverage beat construction. Distance to first contact shrank, and when distance shrinks, outcomes move. Disaster response literature says it, but families say it better when the fever breaks before night. People changed with the timetable. Before, mothers waited until pain forced a decision. After, they came when cramps began. Before, fathers wrapped wounds with plastic. After, they carried a kit card and knew where the bus would park on Thursdays. Most Americans do a version of this already. Urgent care first, hospital if needed, because proximity wins. Human behavior travels the shortest path to relief. If care can reach you sooner, you ask for it sooner. If you ask sooner, you lose less. Skeptics looked for the crack in the plan and found one they recognized: roads. The response wasn't a promise, it was a sequence. Patrols adjusted to escort windows. Detours pre-mapped for washouts, overnight stops listed by terrain and threat level. Radios tested at shift change. If a corridor went dark, the unit rerouted and the slot rolled to the next village. Failure wasn't forbidden. It was priced in, the way airlines plan for weather. Keep moving, keep the line alive. Don't strand the most fragile cases at the edge. If this was your county, would you take a rolling clinic tomorrow or wait a year for a new wing? Would you trade polish for presents if it meant your neighbor's kid got oxygen at 2 a.m.? According to most voter surveys, Americans say they want both, but choose speed when it's personal. People, if they can solve a problem today, rarely hold out for a prettier version tomorrow. The pictures were ordinary and new at once. A bus door folding open in dust, a nurse taping a hand-washing poster to a wall, a father blinking under bright LEDs while a monitor beeped steady instead of frantic. None of it was cinematic. All of it was the point. And as the schedule settled and the routes stopped feeling experimental, one truth got louder in the quiet between radios. Machines can move the light, but people decide where it lands. The first backlash didn't come from enemies. It came from friends with calculators. Allies who loved the headline but circled the spreadsheet asked for proof before praise. On the record, opposition figures called for a public audit of the $60 million drawdown. Fiscal hawks warned about one-time money for a permanent problem. Two health coalitions requested independent verification of coverage targets and cold chain integrity. Radio panels debated whether refurbished fleets could survive the rainy season. The health ministry responded in process, not poetry. Weekly route logs published to district offices, drug withdrawals tracked by biometric locks, uptime and breakage reported with variance notes, routes rotated if corridors went dark. Support wasn't unconditional. Oversight was demanded in daylight. International commentary split fast. Development advocates said scale matters. Security analysts asked if escorts would stretch patrols too thin. Donor agencies wondered if refusing grants in Phase 1 would choke expansion. The presidency held the line. Domestic funds first approved the model. Outside capital later, only if it didn't dictate terms. Help wasn't banned. Dependency was. If you're watching from the US, you know this debate. Local control versus outside dollars. Most Americans prefer private solutions until delay threatens a family member. Then suddenly whatever arrives first is good enough. On the ground, skepticism faced repetition. A shopkeeper told a reporter he wouldn't trust a bus with his child's fever. 3 weeks later, he was the one holding tape to keep the entry clear. A birth attendant, once dismissive of foreign tricks, watched prenatal checks under LED light. The next Thursday, she asked how to use a blood pressure cuff. Before, families waited for certainty. After, they waited for Thursday. Doubt didn't vanish, it adapted. Critics called the model cosmetic. Staff rosters said otherwise. Teams were built from local memory, drivers who knew sand ruts by feel, nurses fluent in market dialects, technicians trained to troubleshoot under a tree. According to emergency care studies, people seek help faster when they recognize the system. If they can speak the language, they speak sooner. And when they come earlier, outcomes shift. Most Americans prove the same habit. They pick the urgent care clinic 10 minutes away over the flagship hospital an hour out. Familiar beats perfect when time is the cost. Media wanted photo ops. Communications declined. No ribbon cutting, no celebrity drop-in, Just press notes listing districts served, stock consumed, hours logged. The most powerful talking point wasn't humanitarian, it was operational. Shorter distance to first contact, more predictable presence. Fewer nights when a radio begged for an ambulance that never came. Optics gave way to oxygen. And if this were your county, would you still hold out for the prettier plan? Habits shifted quietly. Fathers who once tied wounds with plastic now carried gauze. Grandmothers who trusted kerosene now boiled water and asked for cotton. Rumors that the bus might not come lost ground to those that said, "It arrives at dawn." Change didn't shout, it kept a schedule. And between a spreadsheet in the Capitol and a doorway in the bush, politics began to look less like theory and more like math. The first national health metrics didn't whisper. They broke patterns. Malaria deaths in targeted provinces dropped by 62% in 90 days, a figure confirmed by the National Institute. Not projected, not theorized. That kind of movement usually takes years. Here it arrived with engines, not blueprints. The international reaction mirrored the numbers. Neighboring ministries requested schematics within weeks. Delegations visited conversion yards. Regional outlets profiled a soldier president for a health initiative rather than a military campaign. Skepticism still held. Think tanks in Brussels warned of collapse under its own weight. Donor agencies flagged sustainability, but replication moved faster than critique. Togo ordered a pilot, Mali sent engineers, Ghana asked for training runs. In politics, imitation is usually slow. In survival, speed is contagious. On the ground, the shift was quieter but sharper. Families who once accepted fever as fate now expected a test before nightfall. Birth attendants who once prayed for daylight now counted sterile gloves as routine. The contrast wasn't dramatic, it was daily. And daily is what turns improvisation into institution. Human beings, when given a pattern that works, repeat it. When the pattern saves their children, they defend it. For Americans watching, the paradox feels familiar. At home, counties argue over budgets for ambulances while ribbon cuttings draw the cameras. Yet surveys show most parents drive past the brand new hospital to reach the small, urgent care that can see their child tonight. It's the same trade everywhere. A polished system that arrives late, or a rough system that arrives now. Choose A, and you get optics. Choose B, and you get oxygen. Which one feels like a nation's real strength? Burkina Faso placed its bet, and the evidence is rolling mile by mile. The gain is presence, the loss is certainty. Critics ask whether the buses will last 5 years. Parents ask whether their child will last tonight. Policy lives in those competing clocks. And somewhere between the skepticism of capitals and the relief in villages, a line has been crossed. The expectation that care belongs here, not someday, but today. Engines keep turning. Tires press routes once marked as void. And in the dust behind each bus, the idea lingers. If health can move like this, what else have we been told must stand still?